nevertheless, I was asked to tell you how to do it, but definitely this is something that just cannot be done. Most of the people who implant VADs definitely know very well how to do it and what to do. So what I try to give you is a short overview, so how we do it in Vienna, or some points that have been established over the last years. Very briefly, and I think all of you know the slide that I show here about intermax levels. This is just the setting of the scene. So the different patients that are referred for VAD implantation, depending on the clinical status and how fast you have to decide to implant the VAD, either a short mechanical support, like the discussion we had just with the speaker before me, also the long-term support of patients for whatever outcome, bridge to transplant, destination, bridge to candidacy, whatever. Very importantly, I think, is, and this is just very, very new data from Jim Kirkley and from the Intermax registry, it really depends, the outcome, the long-term outcome, the mechanical support really depends on what status the patient is prior to implantation. You definitely can see that there is a significant difference. The lower the number, so the worse the patient is prior to implantation, the worse is the outcome, which we also learned in, I think, most of cardiac surgery and also cardiac transplantation. So there's a cut point where you might think, well, maybe a permanent VAD might not be the best solution in these patients, depending on how the status of the patient is prior to implantation. On the other hand, quite interesting also the long-term outcome. There are more and more long-term outcome of the VAD, which is medium-term outcome, just 2-3 years. When you compare bridge to something, candidacy, a bridge to transplantation, in contrast to destination patients, you definitely see there is a difference. So the bridge to transplantation patients have a better outcome, midterm or long term. Well, maybe because the biasing, there is, you always have the bailout strategy of transplantation that you would not have in a destination patient. So looking at the data of Vienna, you can see there is, like in the early 90s, like in cardiac transplantation, there has been a huge increase of new implantations in the Vienna program. So we now do around 50 VADs a year in our program. And what you also can see in the yellow bars, the numbers of patients who are on the VAD right in the moment are also increasing. So we have more and more patients with long-term support, patients who won't have any higher priority on the waiting list for transplantation. A lot of patients bridge to candidacy who are right now not candidates for transplantation, and we have an increasing number of patients who are destination patients. When you look at the survival, well, it's quite good, especially when you look at the 33% of the patients, this is from 2006 to 2012, you see still quite a high number of Intermax classification 1 patients that were implanted with a VAD, and you still can see, well, there is a room for improvement, especially early on after the implantation of the VAD. So similar like most cardiac procedures, you have an early increase of risk that the patient might die due to the surgical procedure itself or problems associated early after VAD implantation. So how to improve? I think the most important point is to minimize the cumulative trauma of the VAD implantation and really to avoid the classic foes, the foes that we fight when we implant the VAD, which is bleeding after VAD implantation, acute right ventricular failure, multi-organ failure, sepsis, neurological or peripheral embolic events, and of course in the long-term patient, infection. So to give you an overview before I come to the points how we try to tackle these problems, I try to set the scene with the problems themselves. So this is data from I think the 2 big trials by Slaughter and Pagani on the new VAD generations and from the newest Kirkland Intermax registry data. So what are the adverse events? And you still can see the main areas of improvement after VAD implantation definitely is bleeding, it's infection, it's right ventricular failure, and cerebral vascular accidents. And I think putting these these different studies next to each other, I think still the problems remain the same. And these are the ones that we have to tackle to get better results. Timing of complications is very important. You can see any adverse events, so very early on, adverse events start to arise, and you can see that the most early complication definitely is bleeding. And this is completely associated with the implantation of the VAD itself. And you have intermediate complication during the first 30 days, maybe that's mainly infectious problems, that also is associated with the direct implantation of the VAD. And then you can run into long-term complications like today at a very lower risk device malfunction, because the devices today have become much better, technically much better than the older devices, but also cerebral vascular accidents and also some bleeding problems long term. There has been a very recent publication in the journal, in the JAC, just this year, and it's quite interesting. They looked at readmission of patients after the VAD was implanted, went out of the hospital, and what were the causes and the numbers why they had to come back and be readmitted to the hospital. I think this is quite also, it's important to show this also to the authorities to see, well, it's not that high, but still it's something that we have to put our eyes on. So the main causes for readmission, again, bleeding, cardiac causes, sometimes what we run into in our patients with long-term VAD support, long-term right ventricular problems, infections, and also thrombosis. They are the main causes. And you can see differences between early and later periods of readmission. The earlier periods, you mainly have patients that come in with bleeding, some cardiac events, and infection. And in the later period, more cardiac events, bleeding, and thrombosis, either pump thrombosis or cerebral vascular accidents. So the rate of readmissions after VAD implantation, again, you have the months on the x-axis, and you can see it starts to drop the farther the patients are out after implantation of the VAD, but still it stays at the constant level and maybe have a small increase again after 2 years or so. So there seem to be some problems arising later on after the implantation. So the question, right ventricular failure, the question is, okay, if we think a right ventricular failure might develop, why not just implant a biventricular assist device? That was, I think, an old way of thinking, just put in biventricular and to get rid of the right ventricular problems. Well, maybe yes, but the problem is the long-term outcome with biventricular support is significantly worse compared to left ventricular support. So I think you have to really take care and maybe try to work on getting rid of right ventricular failure or getting around right ventricular failure during the operation room. And I think there has been quite a nice publication by the Cleveland group showing some way an algorithm how to work if right ventricular failure shows up in the operation room after LVAD implantation. So if it's mild and moderate, you should maximize inotropic support, use NO inhalation, or maybe use prostacyclin. If it's severe, you have to implant a right ventricular assist device, maybe a temporary, like an ECMO support, what we do in Vienna. And then you can see and put the patient on the ICU and see if it is improving. If it's still might moderate, well, you could wean the NO, wean inotropics, and go around the right ventricular failure or right ventricular problems early on, or if it's worsens, you have to implant an RVAD. So this is quite an interesting algorithm, and it looks very easy, but of course it's always tough to decide in the operation room, so can we get away with it, or are we running into problems? And I remember we were quite aggressive in planting ECMO support for some days in the VAD patients, peripheral implanted ECMOs to see and to give the right ventricle some time to recover from surgery. Very important, you have to have the balance after we implant the VAD between thrombosis and bleeding. Early on, and also for the long term, all of these patients have to be anticoagulated. And this is quite a balancing out and not to go into one of the other problems. If you can see, there are definitely comorbidities where you might have to consider with your anticoagulation, go higher or lower, and you have to be, it's very important that age is a very important point for bleeding. That's a risk factor for bleeding. And with these continuous flow pumps today, most of the patients develop some this acquired Willebrand deficiency, and this can produce bleeding problems even in the long run after implantation of the VAD. And this has been quite a nice overview of the different anticoagulation management, because the different VAD pumps seem to need different kinds of anticoagulation levels. You can see the HeartMate 2, the Javik 2000, and the hardware, and I think Martin Strieber, you published something on the anticoagulation with the hardware that it's different than the HeartMate 2, and you can see with the HeartMate 2 you could run in the range of 1.5 to 2.5 INR, whereas with the hardware you have to go around 2 to 3, and most of the patients, all of the patients should be on aspirin. But still, you have to be very careful, and something that we also learned. Patients show up with infection of the VAD, and all the anticoagulation really runs havoc, and you have to take care of that in the long term after VAD implantation. This is one of the biggest problems that we have with our patients, is infection. Not just driveline infection, but also sepsis early on. And you can see, of course, which is quite a no-brainer, the worse the patient status is prior to implantation, the higher the risk to develop infection. This is quite clear, I think, for most of surgical procedures in cardiac transplantation. But also older age has its impact, and earlier implant area, this was a risk factor for higher rate of infections, something where we learned from. The timing of infection, which is quite clear, early on you have a significantly higher risk during the first month after implantation of the VAD, but it stays quite stable. There's a constant but lower hazard to develop infection after VAD implantation. And to give you a clear point, infection after VAD implantation is associated with a higher risk to die. So it's very important either that you don't have an infection, or if an infection occurs, that you treat it very aggressively. This is very important if you have patients on the long term after VAD implantation. And very recently, the ISHLT has put together guidelines or definitions of VAD infections, because we have to speak the same language when we discuss different VAD infections, like driveline infections, pocket infections, mediastinitis. I recommend that you read this article, because it's very good, and it gives a good overview about the different areas where these infections are. So if you want to work, or if you want to really describe a VAD infection with other colleagues, it's very important to use this terminology. And of course, there is no talk about VAD infection, driveline infection, unless you show some of these, and they can really look horrible. This is still the long-term problem in VAD patients. What we learned, we have a lot of patients who gain a lot of weight after implantation of the VAD, and these drivelines, especially in the obese patients, can be a problem. So in most cases, luckily, local therapy and antibiotics will help, and you can get rid of the infection. But if it stays on, or if it gets worse, you really have to get aggressive surgical debridement, VAC therapy maybe in ongoing or severe cases. Luckily, over the last years, we were not pushed to explant the VAD due to driveline infections. But I think it's most of the point is that we aggressively early on treat these patients. So what doing with severe infections like pocket or pump infections? They are really severe complications. Seldom, but if they happen, you really have to diagnose them quickly, because this is the only chance for treatment. Of course, with the new pump generations, they're much slower, they're in the pericardium, you have a significantly lower incidence. But you really have to do a combined aggressive therapy, surgically plus with the help of the infectiologist to really treat bacteria that's in there. This is mandatory, and sometimes pump explantation might be the last effort, or maybe sometimes in some patients high urgent transplantation, like I would say in Eurotransplant. This is also one of the Eurotransplant reasons that you can put the patient on high urgent. Nevertheless, the outcome is bad, especially if time is lost. So neurological complication, and I put it right after the infection because you can see some of these risk factors. Infection itself is a risk factor to develop neurological complications. I think this is important to keep in mind, and also the history of several accidents is also a problem. So what can be done to decrease the complication? The key factors, preoperative optimization of the patient is very important. Minimize the surgical trauma, minimize the trauma of cardiopulmonary bypass, or even in some cases avoid cardiopulmonary bypass. Avoid postoperative episodes of low output and high vasopressor support, and extubate and mobilize the patients as soon as possible. So there are different areas like right heart, lung, kidney, liver that we really put in different groups where we would try to reach certain parameters, the goals, before we would implant the VAD. So if a patient is not in these desirable values, so the patient with an evidence of right ventricular dysfunction preoperative, you should be admitted to your hospital, aggressive management, you should work on diuresis, ultrafiltration maybe, put them on inotropes, put in an inotropic balloon pump, or even short mechanical support, what we do in crash and burn patients, Intermex 1. So once they're optimized, right ventricular function should be reassessed to see if these patients have recovered from these right ventricular problems. Lung, it's very important. The goal is to have awake, spontaneous breathing patient, not intubated. If this is not possible, the patient should be in short-term, let's say on a short mechanical support, should have a low FiO2, low peak pressures, normal tidal volume, and no pulmonary infections. Very important. Don't push yourself to implant the VAD. Wait to optimize the patient. Pronounced pleural effusion, delay surgery if pulmonary infection has occurred. Looking at the kidney function, so there are some creatinine levels below 2.5, a lower BUN. Patients with a volume overload or poor outcome in the setting of renal dysfunction should have a period of hemodynamic optimizations, so even with inotropic support if necessary, and combined with aggressive diuresis or mechanical volume removal by filtration. And I think liver function is a very important point in cardiac surgery and VAD implantation. So there are different scores that you can do and see, mainly there like the MELT score, which was mainly done for liver transplantation, but you can also transfer them for the risk of VAD implantation. So you should be very careful of patients with elevated INRs if they are without anticoagulation therapy prior to implantation. So this should give you the idea that there might be something wrong with the liver due to long-term right ventricular overload. And it's very important to have the optimized nutrition and the right-sided intracardiac filling pressures. Intraoperative management, well, anesthesia is done with these drugs. Inotropic support, I don't know if levosimendan is approved in the United Kingdom. This is a drug that we can use and use quite often during implantation or after implantation of mechanically assist devices. Use vasopressor support, right ventricular management, avoid excessive pump flows early on, and use and position the cannula optimal with the help of an echo, transesophageal echo, the inflow cannula before you wean the patient off bypass. And coagulation management is mostly done with the TEG guided. Surgical management in the last 6 months, Daniel Zimpfer really has changed his way of implanting most of the VADs, and more and more VADs are implanted, let's say, in the minimal invasive techniques. So if it's only an LVAD, the surgical access would be bilateral minithoracotomy, and the circular support would be either off-pump completely, or if an ECMO, with an ECMO if the patient is unstable. So we had some patients who were crash and burn, were implanted an ECMO and were put with the ECMO to the OR. The VAD was implanted in a minimal invasive technique, and the ECMO could be explanted on the next day. I think this is definitely something very interesting for the future. If you have to do also aortic valve replacement in the patient or tricuspid repair, still lateral minithoracotomies, upper hem, this is the way how we do it, upper hem stenotomy, the 3rd or 4th ICR, of course with bypass. So in summary, VAD therapy is established a therapeutic option with end-stage heart failure. The results definitely have increased over the last years. However, complications still can worsen the outcome. Right ventricular failure, bleeding, infection, main problems in the early period after VAD implantation was bleeding, infection, thrombosis, cerebrovascular accidents are main problems in the later period, and you have to try to avoid them or to treat them very quickly. Preoperative optimization and less invasive surgical techniques help to reduce complications after VAD implantation. And the most important fact, fast and aggressive treatment of complications is imperative to have a good outcome. Thank you very much.
Andreas, for this great overview. I have one quick question for you. You pointed out that in the long-term follow-up, patients may come back with complications. And if you look at these numbers you showed, it's like 25% per year of pipeline infections, 6-8% of stroke rate. So what do you do to prevent this in the outpatient care?
Yeah. One of the most important points is if patients early on visit us after they are rehabbed, directly after they go out of the hospital for 3-4 weeks, and then they visit us about once a month if everything is fine. At every visit, the drive line is inspected with a lot of care, so people have gloves and face masks, so there would no infection due to just touching it. And if there are any potential infectious areas on the drive line, they immediately receive antibiotics. And when I look back over the last 2, 3, 4 years, the numbers of drive-line infections really has come down. Maybe because we just look at it at a more close fashion. I think this is one of the most important points. In the long run, after the first year, patients don't come on a monthly basis. Some of them go out and stay away for 3 months or so, but they are trained to take care of the drive-line by themselves. And the most problematic cases, as I had mentioned before, are the patients who really start gain weight, massively gain weight, where the drive line is really starting to disappear in the belly, and this is a problem also for cleaning the area of the outcome. But patients also, these patients are trained to have a good look at the drive line, and if they see any slightest changes, they immediately have to come to the hospital. I think this is something where we could get them very early. The cerebrovascular accidents, well, it's always a little bit of a ride between Scylla and Charybdis. It's similar like with immunosuppression. But nevertheless, what we saw over the last years also with the newer pump generation, especially the HeartMate 2, cerebrovascular accidents really went down significantly, also in our patient population. I think because they're easier, the anticoagulation management is much easier, and patients are also trained to do anticoagulation management by their own at home. They have these Coagulation apparatus at home and check them on a regular basis, on a daily basis. And I think this is very important. So you have every day self-control, and patients immediately call you up when something goes out of the balance, and then you can interfere very early before something bad happens.
So patient care becomes a new role, but I think we have to move on in the interest of time.